Hey everybody, and welcome back to another video here at Whiteboard Doctor. We appreciate you checking it out. Interesting topic today, and that is the four shock states: distributive, hypovolemic, obstructive, and cardiogenic. We're going to dive into these four shock states, into understanding them, the pathophysiology, the management, the different causes within each category. But to do that, we're actually going to use a framework that we introduced in the first video in this series. We're going to link it in the video description. It's going to be a framework for understanding undifferentiated shock, and it uses the oxygen delivery and oxygen consumption equation as broken down into really finite parts to understand the diagnosis and management of these four shock states. So definitely check that out if you have not. It's linked in the video description. If you feel comfortable with that, or you want to just go on right ahead, let's rock and roll. If I could just take a quick 60 seconds of your time, I wanted to introduce our newest Whiteboard Medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. All right, thanks for sticking around. So the four shock states, this might be familiar to some of you, maybe not familiar to others, but shock, as we talked about in that first video, we defined as tissue hypoxia. And when tissue hypoxia occurs, it can be from a lot of different things. Maybe the heart isn't squeezing hard enough to pump blood forward. Maybe you're bleeding and don't have enough hemoglobin. Maybe you're in septic shock and your tissues are utilizing an incredible amount of oxygen. We divide these into four general categories of shock to help us better understand what exactly is going on. Within each one of these categories, though, there's multiple different causes. So the first category, and often the most common category, one study from a level 1 center found that of all patients presenting in shock, 64% of them were in something called distributive shock. We will further understand distributive shock and define it in a bit, but distributive shock is also broken down into multiple different subcategories, things like septic, endocrinopathies. Again, we'll talk about this more in a bit. The second most common cause of shock is hypovolemic shock. You could be very dehydrated, you could be bleeding, etc., etc. After that is cardiogenic shock, a pump problem, the heart isn't squeezing hard enough. And the least common cause is obstructive shock. Maybe you have a massive blood clot. You have fluid around the heart causing tamponade. Again, all things we'll talk about. So we categorize shock into these four general categories, but know that these aren't perfect silos. So even within the four categories, so within distributive shock, we're going to talk about a bunch of different things that can cause quote-unquote distributive shock, but all of them behave a little bit different. So we use these four general categories to help us understand shock, but it's not perfect. Things are not totally uniform within each specific category. So to start, distributive shock. What is going on? What is distributive shock? Well, what happens in distributive shock is you often get a degree of systemic inflammation. Sometimes this is from septic shock, or you have an infection that is causing systemic inflammation. This could also be from things like pancreatitis, right, where you get a large degree of inflammation throughout the body because your pancreas is inflamed. You also sometimes see distributive shock with things like endocrinopathies. So maybe your adrenal crisis. Endocrine, I put a P too soon. This is why I shouldn't try to spell things in real time. Not that anyone could read my writing anyways. Endocrinopathies. You can also see this with anaphylaxis, or a severe allergy, where your body starts to have a large degree of systemic inflammation. What happens here is you get vasodilation, or your blood vessels start to dilate, and then those blood vessels get leaky, or the capillaries start to leak more tissues into the interstitium. So the capillaries, many of you know, but you have arteries that go into arterioles, that go into venules and veins, right? And this is kind of what the system looks like all throughout the body, right? Blood flows with oxygen through the arteries. The capillary here, cap, has kind of the gas exchange, right? Oxygen goes into the tissue, CO2 goes into the capillaries, and then blood flows through the veins up to the heart, right? So artery, vein, capillary. Well, these capillaries start to get more leaky, right? They start to have kind of more gaps in them. So then fluid can flow into the tissue to get increased capillary permeability. If we look down here, this equation, this is from the first video. It's the oxygen delivery versus oxygen consumption equation. Because we said shock is that you can't deliver enough oxygen for the amount being consumed. And the reason in this case you're having trouble delivering enough oxygen is because there's a much higher degree of oxygen consumption in distributive shock, right? You have this systemic inflammation. All your tissues are in overdrive. They're consuming a bunch of oxygen. All right. In addition to that, we said you get vasodilation. Vasodilation is going to decrease your preload and decrease your afterload. All right. So this is the pathophysiology going on. With a decreased preload and a decreased afterload, you're not able to deliver as much blood volume, right? If you guys watch that first video, you know that these three things are proportional to the stroke volume, right? And heart rate times stroke volume equals cardiac output, or the amount of blood the heart is pumping around. So the problem here is in distributive shock, you get vasodilation. Your preload's low, your afterload is low, so you can't deliver as much oxygen because your cardiac output could drop. You have increased oxygen consumption in the peripheral tissues. So what does your body do to compensate? Well, compensatory, you get an increase in your heart rate and an increase in your contractility. These two compensatory mechanisms actually lead to an increase in your cardiac output to try to keep up with oxygen delivery, this side of the equation, to keep pace with the amount of oxygen consumption. But at some point, if you get sicker and sicker, this compensatory mechanism, this increase in cardiac output by increasing heart rate and increasing contractility, cannot keep up with oxygen consumption. And that then leads to the tissue hypoxia, right? So the pathophysiology of distributive shock is vasodilation and increased capillary permeability, increased oxygen consumption in the peripheral tissues, decreased preload, decreased afterload. These are all pathologic changes. The compensatory change is an increase in heart rate, increase in contractility. And at some point, if you get sicker and sicker, that compensatory mechanism can't keep up and your oxygen consumption outpaces your oxygen delivery and you go into distributive shock. So how do we treat this then? Well, let's look at the pathophysiology going on. Oxygen consumption, really hard to modulate this, right? There's things you could try to do outside the area of this video. But in oxygen delivery, what things can you modulate? Well, your body already cranked up the heart rate and cranked up the contractility on its own. But we talked about how there's a decrease in the preload and the decrease in the afterload, and that those two things are decreasing the stroke volume. So what we can do is we can give fluids and vasopressors, right? Fluids and vasopressors like norepinephrine or Levophed to increase the preload, so knock that out, and then vasopressors to increase the afterload, knock that out, and as such modulate and increase the cardiac output even more to try to keep pace. So that's the treatment among addressing the underlying problem. To distributive shock, fluids and vasopressors to try to reverse the pathophysiology going on here. So see how this equation, the oxygen delivery and oxygen consumption equation, can guide the diagnosis and management. If you understand the pathophysiology, you can understand how to diagnose it and then how to intervene on it, right? The pathophysiologic change, the compensatory change, and then what we can do to help the body better compensate. All right, so that is distributive shock, the most common cause of shock. Within distributive shock, septic shock is usually the most common, right? An infection that causes, diffuse inflammation throughout the body. But pancreatitis, pneumonitis, other itises can cause systemic inflammation, endocrinopathies, anaphylaxis. Neurogenic shock is often batched in distributive shock, although it does behave a little bit different. Because in neurogenic shock, you don't get the compensatory increase in the heart rate. You remain bradycardic because neurogenic shock is going to be injury to the sympathetic chain, so you can't mount that compensatory tachycardia, but it's still usually batched in distributive shock as well. So that is shock state number one, distributive shock. Shock state number 2, hypovolemic shock. So same exact pattern here. Hypovolemic shock can be from severe dehydration, right? You just don't have enough fluid in the body. It can be from hemorrhage or bleeding or losing too much hemoglobin. It can be from this entity called third spacing, which we don't talk about as much, but it's where too much fluid leaks into kind of other areas of the body. But the two big ones are dehydration, hemorrhage, or, even volume loss. So you have severe diarrhea. Things like cholera can cause severe volume loss. And the progression here is you get severe volume loss, as we talked about. That leads to a decrease in preload. So same pattern. With red, you get a decrease in your preload. All right. If it's hemorrhage, if it's bleeding, you also get a decrease in your hemoglobin, right? So now we're having a decrease in both the cardiac output part of this equation, as well as the arterial oxygen content part of this equation. To compensate, your body increases the heart rate, it gets tachycardic, and it vasoconstricts, it increases your afterload, right? So what that does then is that tries to maintain the cardiac output to keep up with oxygen consumption. At some point, though, if this gets so bad that even increasing the heart rate, increasing the afterload, cannot keep up with oxygen delivery, that is when you start to get shock. You start to get tissue hypoxia. So what can we then do to help optimize the oxygen delivery portion of this equation? Well, if they're bleeding and their hemoglobin's dropped, you can give them blood transfusions, right? You can increase their hemoglobin. If they're in hypovolemic shock, they're dehydrated, their preload is low, you can, we should stay consistent, transfuse PRBCs, packed red blood cells. All right. If it's hypovolemic shock from dehydration or volume loss, and their preload is low, you can give them fluids. So again, see here this equation we can use to diagnose as well as identify what to intervene on. So hypovolemic shock, hemorrhage, dehydration, volume loss. In the United States, hypovolemic shock is mostly from hemorrhage. In other countries that have more cholera and things like that, it could be more from volume loss and dehydration, but primarily hemorrhage in the setting of trauma, which you're going to do blood transfusions. Why in hypovolemic shock are vasopressors not really a good solution? What do vasopressors do? Right? Vasopressors would increase afterload, but your body's already compensating by increasing the afterload. So giving vasopressors doesn't really help this condition that much because the compensatory mechanism going on here is increasing afterload. If we go up to distributive shock, we said, let's give vasopressors here, right? Because in distributive shock, you get vasodilation, you get a low afterload. So giving vasopressors will increase that afterload. Whereas in hypovolemic shock, your body's already increasing the afterload, right? You don't have vasodilation here. This is simply you don't have enough fluid, whether it's because you're bleeding or because you're dehydrated. You don't have enough preload. So you need to address that with fluids if it's dehydration or packed red blood cells. The packed red blood cells will improve the arterial oxygen content. The fluids will improve the cardiac output, right? And these things together will increase the amount of oxygen delivery that hopefully can then keep pace with oxygen consumption. All right, that was shock state number 2. Shock state number 3, cardiogenic shock. So cardiogenic shock is essentially the pump. The heart won't squeeze well enough. And this can be from a lot of different things, right? Maybe you had a heart attack or a myocardial infarction. Maybe you have severe valve disease. You have a really bad valvulopathy. Maybe you have, really bad I already said infarct. So anything that causes myocardial damage, maybe you have really bad, myocarditis, right, or inflammation of the myocardium. Anything that causes that heart to not be able to pump effectively. So what is happening then, right? We have myocardial injury or dysfunction, and the pathophys in this equation, right, heart rate, preload, contractility, afterload, think about what is going to be affected here, right? Because oxygen delivery to go into shock is not enough to keep up with oxygen consumption. And then we know oxygen delivery is proportional to these things. Heart rate, these are all stroke volume together. So heart rate and stroke volume are cardiac output. And then this together, hemoglobin, oxygen saturation, and dissolved oxygen is going to be the arterial oxygen content. So what is deranged in cardiogenic shock? Give you a hint. I said it. Decreased contractility. The pump cannot squeeze well enough. So what your body does to try to compensate here is it increases the heart rate and it increases the afterload because it thinks that by increasing the afterload, you might be able to increase stroke volume and improve cardiac output. The challenge here is the body actually does somewhat of the wrong thing in cardiogenic shock, or it can turn into the wrong thing. Because if the heart is not able to squeeze as well, sometimes its compensatory increase in afterload leads to worse cardiac output because this pump that can't pump that well is trying to push against higher afterload. So this is one of the few times when our interventions sometimes are going to contradict the body's compensatory changes. All right, so what do we do in cardiogenic shock then? What do we intervene on? Well, the easy answer here is if contractility is worse, we increase contractility, right? We use inotropes like dobutamine or milrinone. You can use mechanical circulatory support, Impellas, balloon pumps, ECMO, all these things to help, contractility or take the place of contractility. All right. With the contractility suffering, sometimes we see an increase in preload as well, an increase in afterload. And as we said, these things can, even though the body's doing it to compensate, it sometimes can hurt the cardiac output. It can fall off the curve. So sometimes in these patients, we actually are going to say, we don't want you to compensate. We're going to decrease the afterload. We're going to give an arterial dilator, right? So afterload reduction can sometimes be a treatment. Things like nicardipine, I guess it depends on where you work, but nitroglycerin, nicardipine, clavitipine, all sorts of stuff to decrease the afterload. And then sometimes we want to decrease the preload because sometimes you get this venous congestion, right? If the heart can't pump well enough, you can't pump all the blood returning to the heart. So you sometimes want to diurese them, right? Try to get them to pee off some of this increased preload. So unlike the other shock states, cardiogenic shock, sometimes the compensation the body's doing can be bad for cardiac output, and we have to intervene to get these compensatory mechanisms offloaded by decreasing the afterload, decreasing the preload. And then the thing that makes the most sense here is augmenting the contractility, because that is what is pathologically reduced in cardiogenic shock. All right, so that was shock state number 3. Last but not least, obstructive shock. So obstructive shock is very polyfactorial. Fun word that I wrote. So the causes of obstructive shock are anything that causes obstruction to forward flow. So the big thing is a pulmonary embolism. All right, so pulmonary embolism, if we draw a heart, right atrium, left atrium, right ventricle, left ventricle. The right ventricle is going to pump blood through the pulmonary vasculature to the lungs, right? If we have a huge pulmonary embolism in this pulmonary vasculature, that right heart can't squeeze, and you go into right heart failure or obstructive shock, all right? Another one here, let me delete this, is going to be tension pneumothorax, all right? So tension, oh look, I forgot a Y, tension pneumothorax or PTX. So in tension pneumothorax, you have 2 lungs, right? And then you have a heart that sits here, and this is all encased in the thoracic cavity. Tension pneumothorax means you get a hole in the lung, which causes all this air to leak out into the thorax. This increases the pressure out here. That causes the pressure to increase so much this lung collapses, and it can squeeze on the heart so that the heart can't get enough filling of blood, right? Because all that pressure is pushing on the heart, and as such, it doesn't have enough blood to pump out. That is distinctly different than pulmonary embolism, right? This is that there's pressure squeezing on the heart, so it can't get enough preload to fill, whereas pulmonary embolism is there's too much afterload that the heart is pumping against. So you can see here that unlike, more so than the other categories, there's a lot of kind of polyfactorial causes here. Another big thing is cardiac tamponade. So cardiac tamponade is the heart is encased in a pericardial sac, right? And this pericardial sac can sometimes fill. Ooh, did I freeze here? Touch off. Let's put the touch back on. The pericardial sac can sometimes fill with fluid. The pericardial sac can sometimes fill with fluid, right? And if this fluid is filling up and up, it will also compress on the heart, so it can't get enough preload to fill the heart, and thus it can't pump blood out. So when we talk about kind of the pathophysiology here and then the compensatory changes, it's all super variable. Some have increased afterload, some have decreased preload, some has decreased contractility, et cetera, et cetera. Something that you can count on is that, so we said like some of them cause decreased preload, some cause increased afterload, some cause decreased contractility. Compensatorily, you almost always get an increase in heart rate, right? Because we know heart rate, these three things are stroke volume, these make up cardiac output. So you always see an increase in heart rate. But the other modulation here, the other thing we intervene on, will depend on what's going on. If you have a huge pulmonary embolism, that's going to cause this huge increase in right ventricular afterload. So what we do is we go in and we try to get rid of that clot to decrease the right ventricular afterload. If you have a tension pneumothorax, that's going to cause a huge decrease in preload because all that pressure is not allowing venous filling of the heart. So what do? We can go and we can give a bunch of fluids and then also fix the pneumothorax, put in a chest tube so that there's not as much pressure on the heart, right? So chest tube. Same thing if it's tamponade, that's squeezing on the heart, decreasing preload. We can give fluids, or we can give, and then we drain the fluid with a pericardiocentesis. So lots of variability in obstructive shock, which again is why we're saying these four categories are good for kind of initial understanding, but they're very polyfactorial, they're very multifactorial. Not every state within each one of these general categories causes the same derangements. But those are the four general categories of shock: distributive, hypovolemic, cardiogenic, and obstructive. That is a framework for understanding them as related to oxygen delivery and oxygen consumption based on that first video we did. Again, check out the videos linked in the video description. Let us know what thoughts, comments, questions you have down below. This is a very complex topic, but hopefully that provided you all at least with a structure and framework to start understanding these as related to patient care in digestible and intervenable nuggets. So let us know what you think. Subscribe, hit the bell button, like, all that good stuff. We appreciate y'all. Stay well, keep learning. We'll see you next time. All right, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today's episode is going to be on a foundational topic in medicine, and that is distributive shock. In this episode, we're going to be talking about what distributive shock is, key features, classic presentation, pathophysiology, hemodynamics, oxygen consumption, subtypes of distributive shock, management principles, some landmark trials, practice questions, and much more. So no further ado, let's dive in. So starting with what distributive shock is. Well, distributive shock is a type of shock caused by the loss of vascular tone. And this loss of vascular tone can lead to some degree of maldistribution of blood flow. And what that means is when you have blood vessels, let's just go with the veins, okay? Let's say this is the quote-unquote classical amount of vasodilation. In distributive shock, you lose vascular tone. Okay, you get vasodilation. These veins dilate, so I'll just say they're this size. What that means is the amount of blood flow in this vein is now accompanying a larger space because of the vasodilation. And this gets into another concept called stressed and unstressed volume, which maybe we'll dive into in a future episode, let us know. But what this means in distributive shock is the loss of vascular tone leads to this maldistribution of blood flow where you have more unstressed blood flow, right? You have more unstressed volume. You have a a similar amount of volume in vasodilated blood vessels, and that leads to impaired tissue perfusion because you have less relative volume going through these vasodilated blood vessels to try to perfuse the tissues. So you get some degree of impaired tissue perfusion. And this is despite adequate or even increased cardiac output. So your heart is pumping away, right? Your cardiac output, the amount of blood being pumped out of your heart, is adequate or even increased compared to your baseline. But because you're so vasodilated, you've lost your vascular tone. There's not enough effective or stressed volume in your blood vessels to perfuse your tissues adequately. And the key features of distributive shock, the hallmark features, are decreased systemic vascular resistance, right? That's vasodilation, or that loss of vascular tone, okay? So you get decreased SVR. And in the early stages, as we talked about, your cardiac output usually is preserved or even increased, right? Your contractility, you're often hyperdynamic, that heart's squeezing away. As distributive shock worsens, though, in the later stages, your heart can only handle that type of stress and hyperactivity for so long. So eventually you might actually start to get some myocardial depression or, quote unquote exhaustion, some myocardial injury from kind of that hyperdynamic increased contractility workload. And that may lead to a decrease in your cardiac output in later stages of distributive shock. But in the early stages, you have increased cardiac output and decreased systemic vascular resistance. And we're going to get into both of these things more as this episode goes on here. People often describe distributive shock as this relative hypovolemia. And we've mentioned this a couple times in this episode already because we think it's really important. The amount of circulating blood volume is normal in distributive shock. Okay? It's not like you've been hemorrhaging blood or that you're super quote-unquote dehydrated. Now, you could be hemorrhaging blood or dehydrated and also have distributive shock, but that's not part of the innate pathodrome of distributive shock. The circulating blood volume is actually normal, but that circulating blood volume can be thought of as kind of ineffective or relatively hypovolemic because that vascular compartment in general is all vasodilated. So you have less stressed volume, you have less effective circulating volume because that volume's the same, but that vascular compartment is all vasodilated. So the effective amount of volume is less despite the total volume being the same. Hopefully that makes sense. And again, we're going to go through it more as this episode goes on. So if it doesn't make sense now, hopefully it'll fall into place as things continue. The most common cause of distributive shock, and one we've talked about on this channel many, many times, is septic shock, right? This is distributive shock from an infection when your immune system goes all haywire and causes lots of inflammation throughout the body, leading to distributive shock. And again, we'll get more into that as the video goes on here. So the classic presentation of distributive shock, well, starting with vital signs. Someone walks into the emergency department or comes up to the ICU or goes to the medical floor, and vital sign derangements in distributive shock include what you see in all shock states: hypotension. Now, we have talked about shock in general, and shock has a formal definition, which often involves hypotension, but pathophysiologically, you do not have to be hypotensive to be in distributive shock. Shock in general is inadequate oxygen delivery to tissues on a systemic level. Okay, so you can be normotensive and still be in shock. Although for the formal definition, the one people talk about, hypotension or a MAP less than 65 is often something people discuss. But just know, you do not have to be hypotensive to be in shock, including distributive shock. All right, often you have a widened pulse pressure. So what is pulse pressure? Pulse pressure is the systolic blood pressure minus the diastolic blood pressure. And in distributive shock, the diastolic blood pressure is often very low because of that decreased systemic vascular resistance, aka that vasodilation. And as such, you usually have a widened pulse pressure. You know, someone might be 110 over 30 millimeters of mercury, right? That widened pulse pressure, that diastolic blood pressure is much lower than it should be because of that decrease in systemic vascular resistance. So you walk into a room and a patient's hypotensive, they have a widened pulse pressure and a low diastolic blood pressure. That might indicate that they might be in distributive shock compared to other shock states. Certainly not specific, right? There's lots of different things that can lead to widened pulse pressures, but this is one of those things. And most often patients are tachycardic. So they're most often hypotensive tachycardic with a widened pulse pressure, most evident by a low diastolic blood pressure. Now that tachycardia, remember, if someone's on a beta blocker like metoprolol, that's going to blunt that tachycardia. If someone is in neurogenic shock, they're often bradycardia, which we'll get more into, but distributive shock in general, usually tachycardic, because you have to mobilize that increased heart rate to increase your cardiac output. We've talked about on the channel, cardiac output equals heart rate times stroke volume. We said in distributive shock in the early stages, cardiac output is increased. So how do we increase cardiac output? We increase our heart rate. That's our sympathetic compensatory drive to maintain organ perfusion. So you usually get tachycardia. So vital sign derangements classically would be hypotensive, tachycardic, widened pulse pressure with a low diastolic blood pressure. What about physical exam wise? So you've seen the vital signs and you're like, this seems like it could be distributive shock. Well, what do you expect to see in exam? Well, early and late is how we're going to talk about this again. In early distributive shock, you're usually warm and flushed. Because of that decreased systemic vascular resistance, what that leads to is vasodilation of your cutaneous blood vessels. And that vasodilation of your cutaneous blood vessels is to warm and flushed skin. You often have bounding pulses because of that increased cardiac output, that hyperdynamic heart, that increased contractility to compensate for that low systemic vascular resistance. Usually it's to bounding pulses. And then in the early stages, if you're perfusing adequately, you might have rapid capillary refill. But you see vital signs, someone's hypotensive, tachycardic, widened pulse pressure with a low diastolic blood pressure. You walk in the room, they're warm, they're flushed, they have bounding pulses. All of that might indicate distributive shock. Now, in the late phase of distributive shock, things start to change. And this is because you can't often mobilize that high cardiac output for a prolonged period of time, or we should say indefinitely. And after a while, you can't adequately perfuse your organs. That vasodilation doesn't allow for it. And then you might actually be cool. You might have mottled extremities, poor cap refill. And that's all related to that worsening hypoperfusion that'll happen later on. Okay, so there's some kind of early and late distribution of symptoms here. So now you've seen the vitals, you've examined them, and you're like, gosh darn, this really seems like distributive shock. Are there any laboratory values that can kind of clinch the diagnosis? Well, the answer is no. But there are some laboratory values that could be somewhat indicative. Now, just know these are non-specific. Many shock states will have similar laboratory value derangements. And one is an elevated lactic acid. This is a non-specific lab marker. We should actually do an episode on lactic acids as well. Lots of things can lead to an elevated lactate. It is not specific to distributive shock, but it can be elevated with tissue hypoperfusion or tissue hypoxia that you will see in distributive shock. So an elevated lactate. And then in sepsis, this SCVO2, this is a surrogate mixed venous oxygen. We honestly probably shouldn't even put this in here. There's a very complex value and one that deserves its own lecture. But for those that are, a little more advanced in their understandings, you might see a high SCVO2 or a high SVO2, a high mixed venous in sepsis leading to distributive shock. So no specific lab values can clinch the diagnosis, although some can help you understand if you are not perfusing. All right, what about the pathophysiology? What's actually happening in distributive shock? Well, the primary deficit, as we have talked about, is going to be pathologic vasodilation, right? That decrease in systemic vascular resistance. And what is happening is you get all these inflammatory mediators that cause your blood vessels to vasodilate. And when they vasodilate, as we said, this decreases the amount of effective circulating volume, okay? Or the amount of stressed volume is another way people often talk about it. And when this goes down, we sometimes are not able to adequately perfuse our organs. As we said, our cardiac output increases to try to compensate for this. But if the SVR is so low that we cannot circulate enough effective volume, we will get inadequate tissue perfusion, secondary to that pathologic vasodilation. Now, the different subtypes of distributive shock here are important. Okay, and this is the first time we're going to talk about this. So distributive shock is an umbrella term. All right, it is an umbrella term meant to describe several different causes of shock that behave in a similar-ish, emphasis on the ish fashion. And those are septic shock, anaphylactic shock, neurogenic shock, some toxicologic shock states, and some endocrinopathies like adrenal crises. Now, just note, these do not all act identical, right? Because the pathophysiology for each of them is different, but they follow a similar pathodrome, which is why we all batch them under distributive shock. So we're talking about the pathophysiology of distributive shock. We're saying that there's pathologic vasodilation that decreases systemic vascular resistance and leads to inadequate perfusion. But beyond that, the pathophys is shock state specific. So in septic shock, you get this cytokine storm. You have an infection, your immune system goes bonkers trying to attack this infection. And all those inflammatory mediators that are released, including nitric oxide, lead to vasodilation, capillary leak, mitochondrial dysfunction, and that can all impair oxygen delivery and oxygen utilization. Whereas an anaphylactic distributive shock, this is usually IgE, immunoglobulin E mediated. Your mast cells degranulate, and you get all this IgE that leads to mast cell degranulation, and that releases histamine and leukotrienes, and that leads to vasodilation and increased capillary permeability, and you get other things like bronchospasm and swelling. So that is anaphylactic distributive shock, which behaves differently than septic distributive shock. Neurogenic distributive shock behaves even a little bit different. This is a spinal cord injury. Usually it has to be above T6, and it leads to a loss of sympathetic outflow because the sympathetic chain is injured, it's severed, so you can't get that sympathetic drive. And that leads to vasodilation. And a big difference in this is you actually get bradycardia, right? Because that heart rate cannot mobilize from sympathetic surge because you've lost your sympathetic outflow. So you get bradycardia. Whereas in the other distributive shock states, you get tachycardia. And then other causes like endocrinopathies, adrenal crises, thyroid dysfunction, toxicologic things, anesthetics, nitrates, all these are characterized by this pathologic vasodilation. So just note, we put all these under distributive shock, but you can't silo these, right? They all are different, although they're kind of married by the similar underlying pathology of pathologic vasodilation. All right, what about hemodynamics and this concept of oxygen consumption? So we've talked about shock on this channel before. Definitely check out those other episodes on shock because there's a lot more kind of introductory material on what shock is and oxygen delivery, oxygen consumption, et cetera, et cetera. We're not going to dive into that as much here, but we have a lot of good episodes on that really gets into the nitty gritty, so check those out. But for the sake of distributive shock in this episode, we're going to just talk about different parameters and what you would expect to see in distributive shock. So as we said, the MAP, the mean arterial pressure, can be normal, but most often less than 65 millimeters of mercury kind of qualifies as distributive, well, as shock in general. Cardiac output, as we said, you get pathologic vasodilation. So your cardiac output actually compensates by increasing. It goes up. You get hyperdynamic, right? Your heart rate goes up. In later stages, though, if it can't maintain, you might get lower cardiac output. But in those early stages, cardiac output definitely increases. Your systemic vascular resistance in distributive shock, hopefully this pops into your head because we've been saying it over and over again, is markedly low. This is one of the hallmarks of distributive shock. You get vasodilation, aka decreased systemic vascular resistance. Okay. Your central venous pressure, your CVP, this is something we've talked about on the channel too. Check out those episodes. Just search central venous pressure and they'll all pop up. This is going to be low or normal due to the vasodilation. Remember, distributive shock in and of itself is not a hypovolemic state, but it does often benefit from fluids because you have a relative hypovolemia from all that vasodilation. So your CVP might be low or normal, just depending on how much vasodilation there is. And then your oxygen consumption, your body actually in the early stages is hypermetabolic and hyperdynamic. It is consuming more oxygen than is typical. Now, in the later stages, when you start to have some more mitochondrial dysfunction, especially in septic shock, you might have less or an inability to extract and use oxygen, which can be a really negative indicator as a poor outcome, but in the early stages, you're certainly hypermetabolic using more oxygen. So those are some of the classical parameters you might see in distributive shock with somewhat of a focus on sepsis. So we talked a little bit about the subtypes of distributive shock, but I want to dive into it just a touch more here: septic, anaphylactic, and neurogenic. So we're going to talk about things like the onset, the trigger, the heart rate, the skin exam, respiratory rate, hemodynamics, and then first-line therapies. So in septic shock, the onset is going to be gradual, whereas in anaphylactic shock, it should be sudden. You were exposed to an allergen and you have this sudden anaphylactic reaction. Whereas in septic shock, you got to get an infection as to worsen, you have to develop septic shock. In neurogenic shock, it's usually immediately after a spinal cord injury, right? So neurogenic shock, the onset's going to be after the spinal cord injury. Anaphylactic shock, the onset's going to be within minutes of exposure to the allergen. And in septic shock, it's more gradual. Okay. The trigger for septic shock is an infection. It can be bacterial. It also could be fungal. It also can be viral, right? It could be parasitic. So any infection is the trigger for septic shock. In anaphylactic shock, it's triggered by an allergen, food, drugs, bug bites, et cetera, et cetera. And in neurogenic shock, the trigger is obviously trauma or an injury to the cervical spinal cord or upper thoracic spinal cord, anything to knock out that sympathetic chain. Okay. In septic and anaphylactic shock, your heart rate is tachycardic because you're trying to increase heart rate to increase that cardiac output. In neurogenic shock, you are bradycardic because you don't have that sympathetic drive because you've injured that sympathetic chain. So that's one of the big differences here, is that in neurogenic shock, you are bradycardic, whereas in septic and anaphylactic shock, you're tachycardic. Your skin exam in all these shock states are going to be warm and flushed. Okay. Now, in anaphylactic shock, you also, on the skin exam, usually have urticaria or angioedema or a rash of sorts. And in neurogenic shock, you've lost your sympathetic tone, so you're often dry and not sweaty, right? Because you don't have that sympathetic drive to do that. The respiratory exam is very similar, right? You're usually tachypnic in septic, tachypnic in anaphylactic, although you also might be bronchospastic or have airway edema because this is an allergy. And in neurogenic shock, you might be tachypnic depending on how sick you are, but sometimes your respiratory exam is normal, okay? And then the hemodynamics, which this is kind of something heavily tested in septic shock and in anaphylactic shock, you have low systemic vascular resistance and an increased cardiac output. Okay, low systemic vascular resistance and an increased cardiac output. In neurogenic shock, you still have low systemic vascular resistance, right? Because vasodilation, pathologic vasodilation, is a hallmark of distributive shock. But your cardiac output might actually be low because, as we said, you cannot increase your heart rate to mobilize that increased cardiac output. So your cardiac output might be low compared to it being high in anaphylactic and septic shock. And then first-line therapy for septic shock, fluid antibiotics and norepinephrine. We're going to have a dedicated video we already have a dedicated video on septic shock, so definitely check that out. In anaphylactic shock, you really want to get intramuscular epinephrine. This is absolutely critical. This is life-saving. If someone is anaphylactic, they need intramuscular epinephrine. All right. You can give them fluids, you can give them steroids and Benadryl and all these other things, but they need IM epinephrine. In neurogenic shock, vasopressors, norepinephrine, phenylephrine, address the bradycardia, all that good stuff. Again, we'll have some dedicated videos on anaphylactic and neurogenic shock that we're coming out with, and then we already have dedicated episodes on septic shock for you to check out. All right, we're getting closer to the end. So management principles, we've kind of touched on above, but we just wanted to reinforce the point. So initial resuscitation of distributive shock states usually includes some degree of fluids, right? There's lots of discussion and debate about 30 cc's per kg in septic shock, and we're just going to leave that one as is, but that is a recommendation by, the SEP 1 criteria and all that kind of stuff. But usually you need at least some amount of fluids in anaphylaxis. And neurogenic's tough because that heart rate's lower. So you just want to be careful with fluids, but, probably some fluids in neurogenic shock too. So that initial resuscitation is often volume. Okay. After that, though, vasopressors are commonly needed. And norepinephrine is first line in septic shock and honestly most shock states, with the one caveat being, remember, in anaphylaxis, you need that IM epinephrine. If that doesn't work, times two, sometimes you even need to put them on an epinephrine drip. So epinephrine is the vasopressor you want in anaphylaxis. In septic shock, though, norepinephrine is first line. Vasopressin is an adjunct vasopressor we've talked about all all these vasopressors in previous episodes, so definitely check those out. And in neurogenic shock, some people like phenylephrine. Phenylephrine is an alpha-1 agonist, so it just vasoconstricts, whereas norepinephrine has alpha-1 effects, but also has beta effects. So it vasoconstricts, but also can increase contractility a little bit. But norepinephrine, again, first line in most shock states, other than anaphylaxis, which you really need epinephrine. And then there's some adjuncts that people talk about, right? Steroids and septic shock, antihistamines and steroids and anaphylaxis. Do those work is unclear. In neurogenic shock, addressing the bradycardia with atropine or pacing, or sometimes low-dose epinephrine, are all things to consider in terms of management principles. And we'll be doing deeper dives on all these individual shock states, where we'll get into some of the nuance of the management. This is just somewhat of an overview. Obviously, targeting a MAP greater than 65 millimeters of mercury, monitor for lactate clearance, which is really just saying AKA improving tissue perfusion, whether you use lactate or some other marker like cap refill, urine output, end organ injury improvement, all that kind of stuff. All right, there are some landmark trials. We're not going to go through any of these. We're just going to read them out so you know they exist. None of them are super relevant to this episode, although they are very relevant to the management of the different distributive shock states. So there's early goal-directed therapy by Rivers et al. In 2001, published in the New England Journal of Medicine, which then was followed by Process, Promise, and Arise in 2014 and 15, that kind of looked at early goal-directed therapy versus usual care. There's the VAST trial that looked at vasopressin. There was the SOAP2 trial that looked at dopamine versus norepinephrine, adrenal and approaches, which are stress dose steroids. Again, all these are important, and we'll leave them here for your perusal, but none of them are super relevant for this episode itself. All right, should we get into some practice questions? We'll have 3 practice questions. We just, if you're watching the video, we just peeked an answer in, sorry. 3 practice questions, beginner, intermediate, advanced. The way we do these is we'll read the question, we'll read the answer options, and then we'll go right into the answer. So if you need more time to think about it, just make sure you pause the episode, because we'll just dive right into the answer. So question 1, beginner. A 55-year-old man with fever, hypotension, tachycardia, and warm extremities has a lactate of 4. Which shock type is most likely? A, cardiogenic, B, hypovolemic, C, obstructive, or D, distributive? Well, you know the topic of the episode, so the answer most likely is D, distributive. So why, right? We have a patient who is hypotensive, so you're like, uh-oh, they're in shock. They have compensatory tachycardia, so you're like, okay, their heart seems to be trying to compensate. They have warm extremities, which essentially means vasodilation, aka a low SVR state. And then the kicker here is they have a fever, which usually means infection. So in this case, distributive shock makes sense, right? Because they have low SVR because their extremities are warm. They have a fever to imply infection, which could be septic. And then they're in shock with hypotension and a reflex tachycardia. All right, question number 2, intermediate. We keep previewing the answers. Apologies. A septic shock patient remains hypotensive after appropriate fluids. According to current guidelines, what is the first-line vasopressor? A, dopamine, B, norepinephrine, C, epinephrine, or D, vasopressin? The correct answer is B, norepinephrine. So in septic shock, in most shock states, norepinephrine is going to be your first-line vasopressor. Vasopressin is going to be an adjunct that can be used later. Dopamine is no longer recommended. And then epinephrine is really only first line per kind of test questions, although in the clinical arena there's lots of nuance to this, but per test questions for anaphylaxis when it comes to distributive shock. All right, last question, and then everyone can go on enjoying their day and just crushing distributive shock management. Oh, we spaced out that we put the advanced one as something based on trials, which we then brushed through. But that's okay, still good learning here. Which trial demonstrated no mortality benefit of early goal-directed therapy compared with usual care in septic shock? A, VAST, B, Process, C, SOAP2, or D, Adrenal? The correct answer is B, Process, right? So there's 3 trials, Process, Promise, and Arise. And these looked at early goal-directed therapy versus usual care. Now, the thing to note is usual care at this point was now very kind of aggressive in intervening early because early goal-directed therapy brought such a spotlight onto septic shock management, but they did show that the kind of bundled care used in the EGDT trial, the early goal directed therapy trial, did not seem to improve outcomes as compared to usual care, although usual care had evolved to include some of the things done in the early goal directed therapy trial. All right, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. We hope everybody's having a good day, whether you're working clinically or getting educated, getting learnt. We hope everyone is doing all right out there. We today will be talking about a very central topic in emergency critical care medicine, and that is hypovolemic shock. We'll be talking about what hypovolemic shock is, etiologies, classic presentation, pathophysiology, some hemodynamics, oxygen consumption, subtypes of hypovolemic shock, management principles, landmark trials, a couple practice questions, and much more. This is another episode within our shock series where we'll be talking about all things shock. So if you have an interest in shock or you want to expand your knowledge base, definitely check those out. We have a playlist where we're kind of putting together all the episodes on shock, and you can certainly access them on our page as well. Friendly reminder, none of this is intended to be acted upon as medical advice. Please stick around to the end of the episode for a full disclaimer. All right, hypovolemic shock, starting with an overview. So, of the shock states, hypovolemic shock is probably the, easiest to grasp, quote unquote, right? We've talked in the past, there's 4 different kind of umbrella shock states. One is distributive shock. This is septic. This is anaphylactic. This is endocrinopathies, neurogenic. There's hypovolemic shock that we're talking about today. Then there's cardiogenic shock. This might be from heart failure. This might be from a large myocardial infarction. It might be from valvular disease. Then there's obstructive shock. There's things like massive pulmonary embolism, tamponade, tension pneumothorax. And we'll be going over all of these. We actually came out with the episode on distributive shock already. But these tend to be a little more complex than hypovolemic shock. With that being said, though, hypovolemic shock, particularly the hemorrhagic component of hypovolemic shock, is something that you definitely will come across in the clinical arena. So defining hypovolemic shock, this is obviously a form of shock, right? And this form of shock is due to decreased intravascular volume, right? That might be from, severe dehydration. This is not something that we often see, but it can be seen, especially in folks who, maybe have been in the wilderness and those types of things. Some kind of ultra athletes at times too. But much more commonly, this is from things like hemorrhage, and we'll talk about the different subtypes later on. But this decreased intravascular volume leads to inadequate preload. This inadequate preload then leads to decreased stroke volume and ultimately decreased cardiac output. That decreased cardiac output then leads to impaired tissue perfusion. So if we break this down a little bit further, your key feature is a decrease in preload. This is the origin of the insult. This is what is occurring. And that decrease in preload, what that means is there's decreased venous return to the heart, right? Those blood vessels are empty. You're hypovolemic. There's not enough circulating volume in the system, so there's less blood returning to the heart. With less blood returning to the heart, you can't fill the heart adequately. And that leads to a decrease in stroke volume, a decrease in cardiac output. If you're listening to this, we're drawing a very poor picture of a heart. Right atrium, right ventricle, left atrium, left ventricle. And you obviously get venous return from your IVC and your SVC. If this venous return is way down, there's less blood going into the heart. Obviously, the filling of the heart is going to be down. Then when that heart squeezes to try to pump that blood out, it will not have adequate stroke volume or cardiac output. What the body does to try to compensate for that is it says, oh gosh, my blood pressure is low, right? I have this blood vessel here, and I have less volume within this blood vessel than I typically do. So I'm going to vasoconstrict that blood vessel to try to decrease the area, the volume that blood vessel represents. So then you kind of get to this more vasoconstricted blood vessel that has less intravascular area. So the amount of fluid, the amount of blood in that intravascular area represents a higher percentage of it, okay? So that vasoconstriction is synonymous with an increase in SVR. SVR, if you haven't seen any of our videos, stands for systemic vascular resistance. And we go into detail in all of this on all these terms and things in our introductory shock lecture. So definitely check that out if you're interested. But yes, the compensation for hypovolemic shock is a compensatory increase in systemic vascular resistance to try to maintain adequate organ perfusion. So to say it out loud again, you're hypovolemic, right? That means you have decreased preload, decreased circulating volume. That means you're delivering less blood, less volume to the heart. That less volume in the heart means that when the heart squeezes, there's less volume to pump out of the heart. So you get a decrease in stroke volume, a decrease in cardiac output. Your body, to compensate, says, oh crap, I have to vasoconstrict. I have to decrease the intraluminal area of my blood vessels to try to increase my blood pressure, right? Because I have less volume in that blood vessel. So compensatory increase in SVR. Etiologies of hypovolemic shock, as we already started to hint at. The two kind of main categories to break it down into is hemorrhagic and non-hemorrhagic. Hemorrhagic is straightforward, right? You got shot in the heart. You're bleeding in your gastrointestinal tract. Maybe you ruptured an aneurysm, right? So trauma, GI bleeds, ruptured aneurysms, all these things can cause hemorrhagic shock. Non-hemorrhagic shock, non-hemorrhagic hypovolemic shock, we should say, can be from a whole bunch of stuff, vomiting and diarrhea, so GI losses. Okay, burns are a big one. Burns certainly can cause hypovolemic shock. There's something called the Parkland formula, which, isn't fully in favor anymore, but this gives you an idea of how much volume these patients need back. And it, suggests that they do have so much volume loss that they can go into hypovolemic shock. Overactive diuresis, this would be tough to totally maintain, but if you took way too much of your Lasix, your furosemide, you could develop hypovolemic shock. Third spacing is another one people talk about. This is when inflammation leads to leaky capillaries, and leaky capillaries then third space the intravascular volume into the interstitial space, right? So if all these are leaky and this volume's leaking out into the tissues, you'll have less intravascular volume because all that volume is leaking out into the tissues. It's third spacing. Pancreatitis is a big one. Peritonitis, really any significant itis that causes systemic inflammation can lead to third spacing. So the etiologies of hypovolemic shock tend to be hemorrhagic or non-hemorrhagic. The classic presentation people probably could guess, right? But from a vitals standpoint, and we're going to talk more about hemorrhagic shock in a future episode, and we'll get into some of the progression of vital sign derangements in that lecture. We're not going to go into it in as much detail here, but vital signs, you often get tachycardia. This is often early, right? Your heart rate increases to try to compensate. Cardiac output equals stroke volume times heart rate. We said in hypovolemic shock, your stroke volume goes down. So your body increases the heart rate to try to maintain cardiac output. So you get tachycardia. Once that tachycardia cannot keep up, you start to get hypotension, right? You get low cardiac output and you cannot fill your blood vessels enough, so you get hypotension. And the other thing you can sometimes get is a narrow pulse pressure. Pulse pressure is your systemic blood pressure your systolic blood pressure minus your diastolic blood pressure. And this tends to be narrow in hypovolemic shock. Physical exam-wise, you're usually cool and clammy. And this is a good rule. When your skin is cool and clammy, it means you're in a vasoconstricted state because all those cutaneous blood vessels are constricted, and it makes your skin feel colder because there's not as much blood, warm blood from your core body circulating through the skin. So any vasoconstrictive state that is equivalent with increased systemic vascular resistance, right? We talked about that, increased SVR. That's going to lead to cool and clammy skin. So hypovolemic shock, you usually have cool and clammy skin. Septic shock, you're vasodilated, so your skin's usually warm. You're going to have delayed cap refill, which just suggests that you're not delivering enough blood to your tissues. And usually have dry mucous membranes, decreased skin turgor, all this suggests hypovolemia, volume down. Laboratory clues, there's not anything super specific, right? Elevated lactic acid is just like delayed cap refill. It just suggests that there's end organ malperfusion. You can sometimes see hemoconcentration where that hematocrit is going to be higher because the blood cells are concentrated because there's not as much circulating volume, all right? And then obviously that would be non-hemorrhagic shock. Hemorrhagic shock, you might see a low hemoglobin. Remember though, you bleed whole blood. So when you are exsanguinating, your hemoglobin may not reflect that. It might look quote unquote normal because you're bleeding all of your blood out, right? For that hemoglobin to drop, you have to have an increase in your plasma volume with low numbers of red blood cells to make that hemoglobin then look low. So this may lag. This may not be an early sign. Don't be fooled, right? Hemoglobins can be normal in a hemorrhagic shock if it's acute. All right, don't be fooled. All right, pathophysiology. We got into this a little bit, but just to reiterate. So the primary defect here is a decrease in intravascular volume. That decrease in intravascular volume leads to a decrease in venous return to the heart or a decrease in preload. When that happens, as we talked about, decreased preload leads to decreased stroke volume, right? Your heart rate will increase at first, but once it can't compensate enough, that decrease in stroke volume leads to a decrease in cardiac output. That decrease in cardiac output causes hypotension, which then causes tissue hypoperfusion. Your body, to compensate, also tries to increase your systemic vascular resistance. It vasoconstricts. That leads to that cool, cold skin. Okay, so decrease in venous return to the heart, decreased stroke volume, your heart rate goes up to try to compensate. When it can no longer compensate, you get a decrease in your cardiac output because, as we always say, cardiac output equals stroke volume times heart rate. Once that cardiac output drops, you'll get a decrease in your MAP. You will try to compensate by increasing your SVR, your systemic vascular resistance, or vasoconstricting those blood vessels. But once that is inadequate too, you will get tissue hypoperfusion. That'll lead to delayed cap refill. That will lead to an increase in lactic acid, right? Signs of end organ malperfusion. End result, you cannot deliver enough oxygen to your cells, so you get cellular hypoxia. Hypoxia is different than hypoxemia, right? Hypoxemia, when there's an EMIA, an emia, that means low oxygen in the blood. Hypoxia just means low oxygen to whatever it's in reference to. Cellular hypoxia, low oxygen to the cells. All right, that leads to anaerobic metabolism, lactate production, and metabolic acidosis. This is what causes that end organ injury, right? Cellular hypoxia. All right, hemodynamics and oxygen consumption. So this is probably straightforward, but again, we're kind of going to repeat some of the themes here so people can make sure they get a full grasp on it. So your mean arterial pressure in hypovolemic shock drops. Your cardiac output drops because you have a less venous return to the heart. Your systemic vascular resistance increases to try to compensate. You vasoconstrict. Your central venous pressure is going to be low, right? Because you have decreased preload, decreased venous return. Your oxygen consumption is going to be increased early, but then as shock worsens, it will decrease because you're extracting so much oxygen in your shock state. All right. So there's the pathophysiologic response, which is you decrease your MAP, right? You decrease your cardiac output, then you try to compensate by increasing your systemic vascular resistance, increasing your heart rate. And once that fails, that's when you get end organ malperfusion. So subtypes of hypovolemic shock, the hemorrhagic and non-hemorrhagic. We just wanted to lay out some kind of cause, onset, exam findings, hemodynamics, and treatment. None of this is that earth-shattering, but hemorrhagic shock cause-wise, right? It's hemorrhage, it's blood loss. It might be from trauma, it might be from GI bleeds, surgery, what have you. Non-hemorrhagic is plasma or fluid loss. We already talked about burns, GI losses, third spacing such as pancreatitis. The onset of hemorrhagic shock is usually very rapid, right? You're starting bleeding profusely, exsanguinating, whereas the onset of non-hemorrhagic hypovolemic shock is usually more gradual. It certainly can be acute, but it's usually more gradual. You have so much diarrhea that eventually you get hypovolemic. Exam findings are very similar, okay? Tachycardia, hypotension, pallor for hemorrhagic, right? Because you're going to be losing blood, so you might have conjunctival pallor, All right. And then exam findings for non-hemorrhagic is mostly dehydration signs, dry mucous membranes, poor skin turgor, where you pinch the skin and it doesn't shoot back down to flat right away. It's kind of lagged because there's not enough fluid, poor skin turgor. Hemodynamics are the same: decreased preload, decreased cardiac output, increased heart rate, increased systemic vascular resistance. And then treatment for hemorrhagic: control that bleeding and give blood. You resuscitate hemorrhagic shock with blood. You're losing blood, you give blood back. Do not give these patients a bunch of fluids. That will not help you, right? It will not replace the red blood cells that are delivering oxygen. It will dilute out the coagulation factors, thus leading to more bleeding. You resuscitate hemorrhagic shock with blood products. Non-hemorrhagic shock, resuscitate them with fluids, right? They lost fluid, give them fluid back. Good. Getting towards the end here. Management principles. So volume replacement is a big one. We already kind of tickled the surface of this. So the volume that you should replace in hemorrhagic shock is blood products. We often talk about a 1:1:1 ratio, which we will talk more about in the hemorrhagic shock episode that'll be coming out. Okay, non-hemorrhagic shock, give some isotonic crystalloids. Lactated ringers is our favorite, although one could make an argument that you could use LR or NS, depending on which of the big trials you decide you want to put more stock in. Source control is incredibly important. Okay, for bleeding, for hemorrhagic shock, that might be interventional radiology, that might be surgery, that might be endoscopy to control the bleeding. Okay, I can give blood products till I'm blue in the face, but until the bleeding's controlled, they're going to remain sick, right? If it's non-hemorrhagic shock, rehydrate them and then treat the underlying cause too. Is this huge GI losses? Treat the GI illness. Is this diuretic therapy? Stop the diuretics. You know, you get the hint there. And then adjuncts, again, more details to come, but in bleeding and trauma, you know, sometimes we talk about tranexamic acid. Warm fluids can sometimes prevent coagulopathy. Keep the patient warm. Don't let them get hypothermic. That will make the bleeding worse, all that good stuff. And then targets, we try to restore the MAP to greater than 65, although in bleeding, there's some argument here that you could target a lower MAP. Watch their urine output, you know, make sure they're urinating adequately, more than 0.5 cc's per kg per hour. Consider trending that lactate to improvement, although again, there's some argument here on the usefulness of trending lactic acid. We have a couple landmark trials here that we wanted to just include. None of this is that pertinent, but they are pertinent for hemorrhagic shock. One is CRASH 2, talking about TXA. Another one is PROPER, talking about 1:1:1 blood resuscitation, and then just some ATLS guidelines. So we'll leave those there if you have an interest in them, but probably not a huge reason to dive too deep. All right. Last but certainly not least, we have our practice questions. The way we do these questions is we read the question answer options and then we go right into the answer. So if you need more time to think, please pause the episode because we're just going to dive right into the answer once we're done reading the answer options. So question number 1, this is more beginner. A 28-year-old man with trauma presents with tachycardia, hypotension, and cool, clammy skin. Which hemodynamic profile is most consistent with hypovolemic shock, right? So this question is essentially asking what the preload cardiac output and systemic vascular resistance is in hypovolemic shock. And if we just speak it out loud, the preload is going to be low or high? Low, right? Because there's decreased venous return because you're hypovolemic. So low preload. The cardiac output eventually is going to be low or high. Well, there's low preload, there's low filling of the heart, so the cardiac output eventually is going to be low. And then systemic vascular resistance, you vasoconstrict to try to compensate, so the SVR is going to be high. So low preload, low cardiac output, high SVR. Which answer option is that? That is answer option A. Hopefully you put the right one at the bottom. And we didn't pause at all. Apologies. But correct answer is A. Low preload, low cardiac output, high SVR. All right, question number 2, intermediate. A patient with upper GI bleeding remains hypotensive despite 2 liters of crystalloid. What is the next best step in management? A, continue fluids. B, initiate norepinephrine infusion. C, transfuse blood products. D, give epinephrine intramuscular. All right, there's essentially, how do you resuscitate an upper GI bleed? Well, hopefully we said it again, over and over and over again, but the correct answer is pause if you need to. C, give blood product. Bleeding patients need to be resuscitated with blood. Okay, they don't need more fluids. They don't need vasopressors. They don't need epinephrine. They need blood. Give them back what they're losing. So hopefully the answer we put down below agrees. Correct answer C, transfused blood products. Good. Last question, more advanced. This one maybe isn't fair because we didn't talk about the trials that much. But which landmark trial demonstrated mortality benefit of early tranexamic acid use in trauma patients with significant hemorrhage? A, the proper trial. B, crash 2. C, soap 2. D, adrenal. The correct answer is, pause if you need to, B, crash 2. This was the one that studied TXA early, within 3 hours. Hopefully we didn't misremember that. Correct us if we're wrong, but TXA within 3 hours for trauma patients who are bleeding. Good. That's all we have for you today. This is a crash course, kind of introductory course on hypovolemic shock. Right. Welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody's having a good day. Maybe it's had some positive clinical experiences or have been deep in the throes of mastering some obscure medical topic. We have been in the throes of our own recording our shock series, and today's episode within that series is obstructive shock. This is particularly important because obstructive shock is approached a little differently than some of the other kind of umbrella shocks, distributive, cardiogenic, hypovolemic, because each subtype of obstructive shock behaves dramatically differently. So this is stuff we will all see in the clinical arena. The physiology can be quite interesting and, of course, is super important. So we're going to be talking about obstructive shock, what it is, its key features, etiologies, classic presentation, pathophysiology, some hemodynamics, oxygen consumption, subtypes and how they behave differently, the management approach to these things, and then we'll get into some practice questions at the end. All right, thanks for sticking around. Obstructive shock. So just to start, an overview of obstructive shock. What is it? Well, obviously it's a form of shock. Hence why we're talking about obstructive shock. But this form of shock is caused by a mechanical obstruction to the blood flow itself. This is either mechanical obstruction of blood flow into the heart, which we'll talk about, or out of the heart. And this then leads to inadequate cardiac output, which then leads to tissue hypoperfusion, that tissue hypoxia we've talked about. Not hypoxemia, which is low oxygen in the blood, but hypoxia, which is not enough oxygen delivered to the tissues. And tissue hypoxia or hypoperfusion is often how we define shock. So we've done a bunch of videos within our shock series, and if some of this is confusing, some of the fundamental principles we talk about in our introduction to shock, talking about the 4 different types of shock. Distributive, right, is one. Cardiogenic is another. Hypovolemic is another, and then today's is obstructive. So check out that episode if this is kind of confusing off the bat, because we will go into some of the fundamental principles in that episode. All right, key features of obstructive shock. Well, the nice thing in obstructive shock is you actually have normal intravascular volume and normal heart contractility, at least initially, right? Because the heart pump is not the problem, at least not the primary problem, and the intravascular volume is not the primary problem, right? Hypovolemic shock has low intravascular volume. Cardiogenic shock has impaired contractility of the heart. Obstructive shock, though, is different. Obstructive shock is when there is that blockage of either blood flowing into the heart or blood flowing out of the heart. And that causes a decrease in cardiac output. The contractility of the heart's normal, but the cardiac output still suffers because there's impaired filling or impaired outflow. And we're going to get more into this, and it'll start to make more sense, we promise, as we go through here. The body then compensates by increasing the SVR, right? SVR stands for systemic vascular resistance. This is somewhat equivalent to vasoconstriction. So increase SVR, for the sake of this, is going to be synonymous with vasoconstriction. So your blood vessels constrict to try to maintain that organ perfusion. Right? So you have a heart here. Those listening to the podcast version, we apologize. We're drawing a poor drawing of a heart. That's the right atrium, right ventricle, left atrium, left ventricle. And you obviously have your superior vena cava and your inferior vena cava that bring blood to the right side of the heart. That right side of the heart pumps blood out to the lungs, right? And those are a bad picture of lungs. And then the blood from the lungs pumps into the left side of the heart, which then goes out into your aorta, which travels to the rest of the body. Okay? So there's either impairment of the filling of the heart or impairment of the outflow of blood from the heart. So the heart itself is not the primary problem. The contractility is normal initially. The intravascular volume itself is also not the problem, right? The intravascular volume is normal as well. There's an actual physical obstruction, obstructive shock, a physical obstruction impairing that venous filling of the heart or impairing the ability to the heart pump the blood out. We did not phrase that well, but an impairment of outflow or the heart's ability to pump the blood out of itself. The etiologies is when this starts to become more straightforward, right? There's kind of three different, pillars or three different buckets of etiology. There's pulmonary causes, pericardial causes, and mechanical causes. The mechanical causes could be batched into one of the other groups, but it makes sense in our brains at least to keep it a little separate. So the pulmonary causes are things like massive pulmonary embolism. And massive pulmonary embolism, for this example we talked about, means that the right side of the heart cannot pump blood out to the lungs adequately because there's a massive blood clot in that pulmonary vasculature obstructing the right side of the heart's ability to pump blood to the lungs, right? There's pulmonary vasculature that pumps blood to the lungs, the heart's on the other side, and there's a huge blood clot here, right? So the heart cannot pump the blood past this to get it to the lungs, obstructive shock. This causes severe pulmonary hypertension, but pulmonary hypertension at its most severe can cause a form of obstructive shock as well. We get a little bit into the gray here because one could suggest that severe pulmonary hypertension causes cardiogenic shock, particularly right-sided cardiogenic shock. But again, that's a little bit into the weeds for this discussion. So pulmonary causes, massive pulmonary embolism is a classic one. Pericardial causes are like cardiac tamponade. Okay, in cardiac tamponade, you have the heart. Again, we're going to do a bad drawing. Apologies for those watching, but none of these drawings are good, so you're not missing too much. The heart sits in a pericardium, right, a sac. And usually that sac sits right along the heart muscle, and there's usually very little physiologic fluid in the pericardium. Okay, but in cardiac tamponade, this pericardial sac starts to fill with fluid. That might be from uremia in patients with renal disease. That might be from blood in patients with, bleeding. That could be malignant if someone has a pericardial cancer. But when this sac fills with blood, at some point the sac will not expand further. Okay, so as it fills with fluid, it starts to compress inwards onto the heart, right? This fluid starts to press inwards because this pericardial sac is rigid. It won't expand any further. So the fluid has to press somewhere and it presses inwards onto the heart. And this constricts the heart's ability to fill with blood because the heart, when it fills with blood, usually expands outwards a little, right? Think about, systole, the heart contracts, diastole, the heart fills, and usually these walls expand outwards. But in cardiac tamponade, they cannot expand outwards. So there's decreased venous filling of the heart because the heart muscle cannot expand outwards in diastole. And that causes obstructive shock, right? Impaired filling, obstruction of that filling from cardiac tamponade. Constrictive pericarditis does the same thing. That pericardial sac is rigid and it's constricting the heart muscle. So again, the heart cannot expand outwards, so it cannot fill with blood. And then tension pneumothorax. All right, tension pneumothorax is when you have a popped lung, a pneumothorax, and your thoracic cavity starts to fill with air. Okay, so our heart obviously sits in the thorax. We're just going to draw a bad thorax. You have lungs in your thorax, that trachea comes down, and then you have a heart sitting in the thorax as well. Okay, so when you get a tension pneumothorax, pop, right? Then all this air, every time you breathe in, is leaking out of that defect into the thoracic cavity. And that eventually fills with so much air that it starts pushing and increasing your intrathoracic pressure. That pressure increases. And that increase in intrathoracic pressure starts to compress down on the venous filling structures of the heart, that SVC, IVC, as well as the heart itself. So you cannot fill the heart. The physiology is similar to tamponade, right? You have lower venous filling of the heart because that intrathoracic pressure is high. Thus, it's compressing the venous inflow to the heart. And then dynamic left ventricular outflow tract obstruction. This is somewhat of an advanced topic, although if you just simplify it to the shock state, it means the left ventricle has an obstruction, so it cannot pump blood out of the left ventricle, obstructive shock. So these are the three kind of buckets of etiologies for obstructive shock, with it being pulmonary embolism, severe pulmonary hypertension, cardiac tamponade, constrictive pericarditis, tension pneumothorax, and dynamic LV outflow obstruction. All right. And as you can tell, each one of these behaves a little differently. They all cause obstruction. They all lead to impaired filling of the heart or impaired outflow from the heart, but they all do it in slightly different ways. Classic presentation of obstructive shock. Well, like with most shock states, you can get hypotension and tachycardia. Your cardiac output equals heart rate times stroke volume. We just said the stroke volume is going to be lower because either the heart cannot fill with enough blood or there's too much afterload, so the heart cannot pump that blood out, so the stroke volume goes up. So to try to compensate, the heart increases its rate to try to preserve its cardiac output, so you get tachycardia. Once the tachycardia cannot maintain that cardiac output because that stroke volume is just so low, that's when you start to get hypotension. And then you often get a narrow pulse pressure. This is classic of hypovolemic shock. You'll have a narrow pulse pressure. Okay, cardiogenic shock, you'll have a narrow pulse pressure. And obstructive shock, you'll have a narrow pulse pressure. So the only shock state that we did not mention that has a widened pulse pressure is going to be septic shock, or we should put distributive shock as the wider category, for which septic shock is a subtype of distributive shock. And we talked about that in a previous episode. So on exam, the physical exam is going to help you understand the etiology of the obstructive shock. So for tamponade, you may remember there's something called Beck's triad. And Beck's triad has the classic JVD, jugular venous distension, muffled heart sounds because that pericardial sac is full of fluid, hypotension, and then you sometimes get pulsus paradoxus. Pulsus paradoxus is related to blood pressure, and we did not, put to memory the exact changes in blood pressure and things, but what happens is when you take a breath in, you spontaneously inhale, that intrathoracic pressure actually goes down, right? Because your diaphragms contract, and what is happening when you take a breath is your diaphragms contract, that decreases the intrathoracic pressure, and then air passively flows into your lungs. In tamponade, when you take a breath in, let's actually say first, in a normal patient, when you take a breath in, that decrease in intrathoracic pressure actually leads to more right-sided heart filling, right? The blood from the venous structures, the IVC and SVC, can flow into the heart more because there's decreased intrathoracic pressure. It creates a gradient where that venous blood flows into the right side of the heart. In tamponade, though, remember, we said the heart has no ability to expand when it's filling. Okay, so when you breathe in and the right side of the heart tries to fill with more blood, but it can't expand outwards, what happens is that septum actually bows into the left ventricle because that right side's trying to fill with blood, and the walls of the right heart can't expand outward, so it bows into the left ventricle, and that decreases the amount of blood in the left ventricle. So when the left ventricle squeezes, you'll actually get a decrease that's even further in cardiac output, and this will decrease your MAP. That's pulsus paradoxus. With inhalation, you have a lower blood pressure. All right. So that's Beck's triad. In the clinical arena, pulsus paradoxus is important. Muffled heart sounds and JVD and things are less easy. If you can do bedside ultrasound, an echo can be super helpful. We will talk more about tamponade in detail and what the echo findings and all that are. We're not going to cover them in this discussion today. All right, tension pneumothorax. So the classical test question findings are going to be tracheal deviation away from the tension pneumothorax because that intrathoracic pressure is building up and pushing the structures away from the area. Absent breath sounds because one of the lungs is popped, has a pneumothorax. Hyperresonance over the chest of that area because, again, it's just full of air. And then distended neck veins. Hopefully all this makes sense. If we go back to our terrible drawing of a pneumothorax, right? You pop one lung, the intrathoracic cavity starts to fill with air, and it's going to push the structures away from where the pneumothorax was. Okay, it's going to compress the venous structures, which then is going to lead to dilated neck veins because that blood's trying to flow into the heart from the neck veins, but it can't because this venous structure is constricted, so you get dilated neck veins. If you try to auscultate, over the side of the pneumothorax, you're going to have absent breath sounds because this lung is all kind of compressed down because that side of the thoracic cavity is just full of air. And then if you palpate, you percuss this side, it's going to be hyperresonant. All right. These are hopefully things that make sense. And then for PE, this one acts way different. Most likely you'll have sudden dyspnea, but it doesn't always get described as sudden. So don't let that fool you. Chest pain, particularly pleuritic chest pain, so pain that hurts worse with deep breaths. Tachycardia, jugular venous distension, because again, your right side has more afterload because it's trying to pump against a large blood clot. So JVD, and then low oxygen levels. But none of these are super specific, and none of them are super sensitive. So you could have none of these and still have a pulmonary embolism. You could have all of these, and it could be from something else. So, just be cognizant. PEs are sometimes tough to diagnose clinically, like just with exam and history alone. Sometimes it's straightforward. My leg's swollen. I just had surgery. I also have cancer. All of a sudden, I had severe shortness of breath. I'm tachycardic, tachypnic, hypoxemic. I have chest pain that hurts worse with a deep breath. That's probably PE, but it's usually not that straightforward. Labs and imaging. We're just going to take a swig of our coffee. Excuse us. All right, labs and imaging. Elevated lactic acid is something you'll see in a lot of these kind of introductory to shock episodes. This is non-specific. This just suggests that you might have organ malperfusion, but it's not specific too. It can be elevated when there's not organ malperfusion. So this is just something that we often send in patients who are worried about shock. Super high lactates can be predictive of worse outcomes, although there's a lot of complexity there. And then labs and imaging, if you can do bedside ultrasound, this can be absolutely, critical in these patients, right? You can get rapid diagnosis. For PE, you might have severe RV dilation. For tamponade, you'll see a big pericardial effusion. Well, I shouldn't say that. It's not always big, depending on the how fast the fluid accumulated, right? The pericardium can expand, but it does it slowly. So sometimes you could have large pericardial effusions in patients with, let's say, end-stage renal disease who are uremic. But those large pericardial effusions build up over time, so it gives the pericardium time to expand, and it might not cause tamponade. Where someone immediately post-cardiac surgery might have a very small, kind of localized effusion that could be causing a type of tamponade because that bleeding happened quick. And then no lung sliding and pneumothorax. So bedside ultrasound, POCUS can be really, really useful in these patients. And we'll talk more about each one of these things when we talk about the subtypes of obstructive shock in future episodes. Pathophysiology. Well, the primary defect here, as we talked about, is there's a barrier to circulation. You either have decreased venous return, say tension pneumothorax, all right, or cardiac tamponade, or you have an increase in afterload that then inhibits the heart's ability to pump blood out. So massive pulmonary embolism is an increase in right heart afterload. LV, left ventricular outflow tract obstruction, is a obstruction of left ventricular, or an increase in left ventricular afterload, that then leads to an inability to pump blood out of that left ventricle. So you either have decreased venous return or an increase in afterload secondary to some type of mechanical barrier. And this then leads to decreased stroke volume. As we said, at first your heart rate tries to compensate by going up, but eventually when it gets too bad, it cannot compensate enough, so you get decreased cardiac output. And as we talked about, just to try to keep repeating themes, so hopefully they stick better with framing in different ways. So for pulmonary embolism, you obstruct the pulmonary arteries. Your right ventricle then tries to pump against that obstruction to get blood to the lungs. That leads to RV strain and failure, and eventually that will decrease your LV preload because you can't get enough blood from the right side to the left side, and that'll cause hypotension and shock. Cardiac tamponade, you have a big pericardial effusion that then compresses the heart. It prevents diastolic filling, and that then leads to decreased stroke volume and decreased cardiac output. Tension pneumothorax, air under pressure within the thoracic cavity compresses the medium sternum. That decreases venous return to the heart because those venous structures are compressed by all the increased intrathoracic pressure. That leads to less heart filling and lower stroke volume. So the end result for all these is the same. Either decreased preload or increased afterload that then eventually leads to decreased cardiac output, which then leads to hypotension and shock. So hemodynamics and oxygen consumption. So this is I think important, but also has to be digested in the clinical context. So we're going to talk about parameters and then whether that's low, high, or neutral in obstructive shock. So the mean arterial pressure, the MAP, you can have physiologic shock with a normal MAP, but for kind of the classical scenario, you're in shock, so your MAP's going to be low. Your cardiac output is going to be low because you don't have enough venous filling or you have too much afterload. Your systemic vascular resistance, your SVR, remember this is a measure of kind of vasoconstriction or vasodilation. So your systemic vascular resistance is going to be low or high. It's going to be high because your blood vessels are constricting to try to compensate for that lower cardiac output. Your central venous pressure, your CVP, this is going to be your preload measure. Is this going to be low or high? It's going to be high, right? Because you get that jugular venous distension, that venous blood's trying to fill the heart, but it can't because there's either tamponade or large PE causing RV dilation or tension pneumothorax increasing your interthoracic pressure. So you're going to get all that venous congestion because the blood's trying to fill the heart, but it can't. And that's going to lead to an increased CVP. Most times, tension pneumo PE, tension pneumo PE and tamponade. And your oxygen consumption, this is one that we probably aren't going to dive into in this video. Oxygen consumption is a really complex topic. It's somewhat time and patient dependent, so we'll leave that there for now. If we talk about the subtypes of shock, and we're going to then talk about pathophysiology, classic findings, and immediate treatment. And the immediate treatment is critically important, okay? Because that's where things differ a little bit. So if we start with massive pulmonary embolism, and we go with pathophysiology, again, we've talked about this, hopefully it's starting to stick. That right ventricle is trying to pump blood, but there's a huge blood clot in the way. So there's RV outflow tract obstruction. That then leads to RV failure, and that right ventricle, as it fails, cannot pump blood from the right ventricle through the lungs to the left ventricle. So eventually your left ventricular preload starts to decrease, and that then causes a decrease in cardiac output and shock. Those classic findings that we talked about, dyspnea, hypoxemia, RV dilation, jugular venous distension, again, none of them are sensitive or specific, but that's kind of the test question caveat. And then immediate treatment. The reason we said immediate treatment for obstructive shock is so important is this is how you fix obstructive shock. We can try our darndest to temporize the patient with, either fluids or vasopressors or inotropes, but what you need to do is you need to treat the underlying cause even much more than in some of the other shock states. That's not totally fair to the other shock states, but in obstructive shock, you have to address the underlying pathophysiology. So immediate treatment for massive pulmonary embolism, thrombolysis, TPA, TNK, embolectomy, anticoagulation, all those types of things, which we've talked about in previous episodes on pulmonary embolism. All right, cardiac tamponade. The pathophysiology here is that there's pericardial fluid that can only expand so far within the kind of fixed pericardial sac. Eventually, it starts to compress inwards towards the heart, which decreases diastolic filling of the heart and leads to shock. The classic findings are Beck's triad, muffled heart sounds, JVD, hypotension. You can get that pulsus paradoxus because when you breathe in, the right side of the heart tries to fill with more blood, but that right side can't expand outwards because of the effusion. So what happens is the ventricular septum bows into the left ventricle, decreasing left ventricular preload and causing hypotension. And then bedside ultrasound will show a pericardial effusion. Immediate treatment, right? Have to address the underlying cause, pericardial synthesis. That's what you need for tamponade, okay? Tension pneumothorax. Pathophysiology, air under pressure. So you have a defect in your lung that leads to air leaking from the lung into the thoracic cavity. That increase in intrathoracic pressure that develops then compresses the venous structures, leading to a decrease in venous return to the heart. You also get compression of the right ventricle because the heart is sitting in that thoracic cavity, and that leads to decreased venous filling again, which then leads to lower cardiac output. Classic findings, again, test question-wise, tracheal deviation, absent breath sounds on the affected side, jugular venous distension. And how do you treat it? Treat the underlying cause, needle decompression, right? Get a large gauge needle, maybe a 14 gauge needle. It used to be that you could do in second intercostal face space mid-clavicular line. The recommendation now is more the fourth intercostal space, kind of anterior mid-axillary line for needle decompression. And then these patients are going to need a chest tube as well, or a finger thoracostomy at least. And then, there's other rare causes. We talked about some of them, like dynamic left ventricular outflow tract obstruction, pulmonary hypertension, tumor compression. And again, addressing that underlying cause, surgery, stenting, ECMO, disease-specific is what's going to treat these. So if you could take one thing away from this portion of the episode, it's you need to treat the underlying cause. This is so important. These patients will not survive if you don't expediently treat the underlying cause, because we cannot temporize them very well without treating the underlying cause. Management principles. Classic things, right? ABCs, stabilize the airway, breathing, and circulation. Use a bedside ultrasound to diagnose. Just know if you have to intubate these patients, many of them are going to be incredibly high-risk intubations because when you take away their ability to spontaneously breathe and you put them on positive pressure, that's going to stress out the right ventricle even more, and it can lead to RV collapse and death. So really, intubation in these patients should not be something you're jumping towards quick. Certainly, there's patients where you don't have a choice because they're going to, die without intubation immediately, but just know, if you're going to pursue intubation on these patients, you better have no other option at all, and you better be ready for just hemodynamic collapse. These are really high-risk intubations. Some folks would suggest you should, not intubate them unless they go into cardiac arrest. We're not taking a firm stance on that, but just that's how serious this can be. Condition-specific interventions we already talked about for pulmonary embolism, thrombolysis, catheter-directed thrombolysis, mechanical thrombectomy, embolectomy, anticoagulation, tamponade, pericardial synthesis, tension pneumothorax, immediate needle decompression followed by a chest tube, all that good stuff, and then support these patients. IV fluids in something like tamponade and PE may help the preload, but if you give an access, it's going to cause RV failure, right? So you might need some volume, but just know there is a curve there where you can fall over that curve and stress the RV out more. Vasopressors just as a bridge, right? Keyword as a bridge until obstruction is relieved, because that's the treatment for these conditions. Goal for all treatment is definitive relief of obstruction. Treat the underlying cause. All right, that's all we have for the main episode today. Hopefully it was helpful. We do have 3 practice questions. For those of you who have not seen an episode with practice questions before, we will have a beginner, intermediate, advanced level question. We will read the question, answer options, and then we'll go right into the answer. So if you need more time to think about it, just pause the episode because we're going to jump right into the answer. Question 1, beginner level. A patient with penetrating chest trauma presents with hypotension, JVD, and muffled heart sounds. What is the most likely diagnosis? A, tension pneumothorax. B, cardiac tamponade. C, massive pulmonary embolism. Or D, hypovolemic shock. Pause it if you need to. The answer is B, cardiac tamponade. This is that classic Beck's triad: hypotension, JVD, and muffled heart sounds. For tension pneumothorax, you would have hypotension and JVD. You would not have muffled heart sounds, and you would see tracheal deviation, decreased breath sounds on the affected side, hyperresonance to percussion, all that good stuff. Massive pulmonary embolism, you'd see hypotension, you'd probably see JVD, there wouldn't be muffled heart sounds. You'd also expect hypoxemia, tachypnea, tachycardia, all that good stuff. And then hypovolemic shock, you'd see hypotension, but you will not have JVD because your intravascular volume is low. You're not going to have muffled heart sounds. It's more just a distractor. So correct answer is B, cardiac tamponade. Question number 2, intermediate. A patient with sudden dyspnea and hypotension is found to have RV dilation on bedside echocardiography. Which of the following is the most definitive treatment as the patient is unstable? A, IV fluids. B, systemic thrombolysis. C, pericardiocentesis. D, needle decompression. Pause if you need to. The correct answer is B, systemic thrombolysis. So in the setting of a test question, sudden dyspnea in the setting of obstructive shock is most often PE, right? So there's sudden dyspnea, there's hypotension, and then there's RV dilation on the bedside ultrasound. If this patient is in extremis, you can make an argument to give empiric systemic thrombolysis, right? Because your suspicion for PE is so high. Obviously, the clinical arena is often more gray than this, and there's more variables at play. But for test questions, B, systemic thrombolysis, with the thought being this is pulmonary embolism. All right, last question, question 3, advance. Which of the following hemodynamic patterns is most consistent with obstructive shock? A, decreased cardiac output, increased CVP, increased SVR. B, decreased cardiac output, decreased CVP,
increase SVR. C, increased cardiac output, decrease SVR, normal CVP. Or D, normal cardiac output, normal SVR, increased CVP. Pause if you need to. The correct answer is answer A, decreased cardiac output, increased CVP, increase SVR, right? Because in obstructive shock, you either have decreased venous filling of the heart or you have increased afterload, and that is going to lead to a decreased cardiac output, right, causing shock. So you automatically know that there needs to be a decreased cardiac output. Then the question is, what does CVP and SVR do? Well, as we said, your systemic vascular resistance increases because the blood vessels are trying to vasoconstrict to maintain perfusion. All right, so we know our SVR goes up. What about the CVP, the central venous pressure? This is the preload. This is the venous filling pressure. And as we said, for most of these patients, their venous inflow is obstructed by something. So they get congested, there's backflow. The venous blood can't enter the right heart the way it wants to, so it causes a high CVP or venous backflow. And that's why the answer is A, decreased cardiac output, increased CVP, increased SVR. Hey everybody, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hopefully everyone's having a good day, good weekend, good week, whatever that might mean. We today are going to be diving into another episode in our shock series, this time talking about cardiogenic shock. So in this episode, we're going to be going over what cardiogenic shock is, key features, etiologies, classic presentation, pathophysiology, hemodynamics, oxygen consumption, some subtypes of cardiogenic shock, management principles, then we'll get into a couple landmark trials and then practice questions. So hopefully this will be a nice kind of introduction or the fundamentals of cardiogenic shock, and hopefully you can all take something from it. Quick 30-second break here. We just want to bring you something we're really excited about. Don't go anywhere. Right after that, we'll dive in. All right, thanks for sticking around. So, cardiogenic shock. By definition, cardiogenic shock is shock due to primarily a cardiac pump failure, right? That's the heart. The heart is failing, cardiogenic shock. This leads to inadequate cardiac output despite normal intravascular volume. And that sometimes changes in patients with heart failure, right? They can get congested and that intravascular volume might actually be high. But in acute cardiogenic shock, this can be a primary heart problem, the contractility of the heart. Certainly that can lead to some venous congestion as not as much blood is pumping through that heart as the veins want to deliver to the heart. But also you can have hypervolemia or high intravascular volume. So in the acute phase, you can have normal intravascular volume. In kind of the heart failure progressive phase, you can have hypervolemia or high intravascular volume. Key features of cardiogenic shock: decrease cardiac output. This is one of those features that's in a lot of shock states. We've talked about kind of the 4 shock states, which are somewhat umbrella terms for some subtypes of shock, that being distributive, which is like septic, anaphylactic, endocrinopathies, neurogenic. There's obstructive shock, which is like massive pulmonary embolism, cardiac tamponade, tension pneumothorax, and then there is hypovolemic shock, and that is things like hemorrhage or severe volume depletion. And then in addition to that, what we're talking about today, which is cardiogenic shock. In obstructive shock, hypovolemic shock, and cardiogenic shock, you have decreased cardiac output. Those are key features. In cardiogenic shock, you often have an increase in preload, a high central venous pressure, a high pulmonary capillary wedge pressure. This is done off a Swan or a pulmonary artery catheter. We've talked about pulmonary artery catheters in an episode, so definitely check that out, but it's a complex topic and one we're not going to dive into here. And this is often due to the idea of kind of quote-unquote blood backing up. All your veins are trying to fill into the heart, but the heart itself is not able to squeeze adequately. So these veins try to fill the heart, but it slows, and in result of that is you get venous congestion, okay? So you have a high central venous pressure, a high preload from that blood backing up because that heart is not able to squeeze as robustly as it usually does. You also get a high SVR. SVR stands for systemic vascular resistance. And for the sake of this episode, you can think of this as kind of vasoconstriction. So a high systemic vascular resistance, a high vascular resistance means there's vasoconstriction. And the body vasoconstricts to try to maintain the blood pressure because that cardiac output drops, which then leads to lower mean arterial pressures, and your body's like, oh shoot. So it vasoconstricts to try to maintain that mean arterial pressure. All right, so you get a high CVP, right, a high central venous pressure. You have a low cardiac output, and you have a high SVR. The low cardiac output is part of the primary kind of pathology of cardiogenic shock, and that leads to a high CVP. And then your body tries to compensate by increasing its SVR, its systemic vascular resistance, or vasoconstricting. We'll get more into that, don't worry. Etiologies of cardiogenic shock. The most common is going to be acute myocardial infarction, especially STEMI. You have a massive heart attack, and that leads to worsening cardiac function. Other things can cause cardiogenic shock, though. Arrhythmias, right? Tachy or bradyarrhythmias. Cardiomyopathies. People who drink too much alcohol sometimes can get a non-ischemic dilated cardiomyopathy. Acute valvular failure. So valvulopathies can cause cardiogenic shock. Things like myocarditis or injury to the myocardium. So you have inflammation from an infection of the heart muscle, the myocardium, or your myocardium stunned after cardiac arrest from all the chest compressions and things. So there are multiple causes of cardiogenic shock, and they do all act slightly differently, but the most common is from acute myocardial infarction. There is a growing population of patients with heart failure that, as they become more decompensated, can develop cardiogenic shock as well. And this is kind of like acute progression of their chronic heart failure, depending on how they're doing and those types of things. But there are, even though cardiogenic shock may feel like a singular pathology, right? My heart is not able to squeeze as well. There are multiple etiologies, and each etiology does behave slightly differently. Okay, so classic presentation of cardiogenic shock. Well, you'll get tachycardic. Now, if you have a bradyarrhythmia, you're not going to get tachycardic, but most patients get tachycardic, right? Because cardiac output equals heart rate times stroke volume. We just said that your contractility, your heart is not pumping, it's not squeezing as well. So you're going to have a decrease in your stroke volume. So what your body do to try to compensate is it increases its heart rate. It gets tachycardic to try to maintain that cardiac output. At some point, that tachycardia is not enough to maintain that cardiac output, and that's when the cardiac output drops. All right, that's where you get the hypotension, and your body's trying to compensate by increasing its SVR, and at some point, if it gets worse, you lose that game, and you end up getting end organ malperfusion or injury to your organs. You also will see a narrow pulse pressure. Right? Narrow pulse pressure is systolic blood pressure minus diastolic blood pressure. And narrow pulse pressure is seen in cardiogenic shock. It's also seen in obstructive shock and hypovolemic shock. So the only one it is not seen in is a distributive shock, right? Primarily septic shock as one of the distributive shock phenotypes. But otherwise, cardiogenic shock, obstructive shock, and hypovolemic shock all have a narrow pulse pressure. Exam findings, these patients are going to be cool and clammy. And the reason they're cool and clammy is we said they get vasoconstricted. They have a high systemic vascular resistance, a high SVR. So all those cutaneous blood vessels are starting to vasoconstrict. That will lead to decreased blood flow to the skin and lead it to feel cooler. You'll get high jugular venous distension because we said the CVP is high because all that venous blood is kind of backflowing. It's getting congested because it can't flow into the heart as readily as it would like to because that heart is not able to squeeze as robustly. It can't pump it out as fast. Because of that venous congestion, you get signs of fluid overload, pulmonary edema, right? Lower extremity edema, anasarca, all that good stuff. And then if you're auscultating, S3 gallop may be present. We're terrible physicians and call our stethoscope the wheeze detector while acknowledging out loud that that's not all the uses for a stethoscope. So please develop good oscillatory skills and you might be able to detect an S3 gallop. Labs and imaging. If it's related to myocardial ischemia, you'll see an elevated troponin. Lactate is most likely going to be elevated, but this is nonspecific. It can suggest hypoperfusion of the organs, but also can be elevated for other reasons. This is kind of just a nonspecific marker in shock. Now, certainly a high lactate is correlated with more morbidity and mortality, so it is very meaningful, but nonspecific. And if you do a bedside ultrasound, an echocardiography, or POCUS, point of care ultrasound, you should probably see a decreased left ventricular ejection fraction. You might see wall motion abnormalities. You might see valvular pathology. So if you've gotten good at echo, this can be incredibly useful in patients with shock states. All right, what about the pathophysiology at play here? We're going to kind of recite some of the things we already talked about and frame them in a way where hopefully they start to stick more by revisiting some of these concepts. So the primary defect in cardiogenic shock is a failure of the pump. Cardiogenic, heart, cardiac, failure of the pump. And that pump failure means that there's often lower contractility. The heart is not squeezing as well. And that lower contractility leads to lower stroke volume. As we said, cardiac output equals heart rate times stroke volume. So to compensate for that lower stroke volume, your heart tries to increase the rate, but maybe you're on a beta blocker, so you can't increase the rate, or maybe you can't increase the rate enough to maintain that cardiac output. So eventually you get a decrease in cardiac output. That leads to a decrease in your MAP, your mean arterial pressure, that hypotension that we talked about. And then that eventually leads to poor tissue perfusion, or that tissue hypoxia. Not hypoxemia. Hypoxemia is low oxygen in the blood, but tissue hypoxia, not enough oxygen to the tissues, or poor tissue perfusion. That's when you see that increase in lactic acid, right? That acute kidney injury, maybe a transaminitis, right? All these things suggest end organ malperfusion or poor tissue perfusion. So that's the progression. Pump failure decreases stroke volume. You try to increase your heart rate to compensate. You try to increase your SVR, your systemic vascular resistance, to compensate. You eventually, if things progress, lose that gain, which then leads to a decrease in your cardiac output, a decrease in your MAP, and poor tissue perfusion. As we mentioned, compensatory responses here. How does your body try to compensate? Well, it increases your systemic vascular resistance. You get vasoconstriction, which we talked about, and it increases your heart rate. But do note in cardiogenic shock, something unique about it, as compared to some of the other shock states, is the compensatory increase in your systemic vascular resistance, your SVR, actually increases or worsens the left ventricular afterload, right? So your left ventricle, we're drawing a, poor picture of a heart, right atrium, right ventricle, left atrium, left ventricle. Your aorta is right coming out of this left ventricle. So if you're increasing your SVR and leading to vasoconstriction, you're increasing the afterload, right? The pressure in the aorta is higher because you vasoconstricted. So that actually stresses out this left ventricle even more because it's already weak and it's trying to pump blood against a higher afterload. So in cardiogenic shock, this increase in SVR can actually be bad for the heart. That's why sometimes in cardiogenic shock, we have to actually put patients on vasodilators to try to decrease that LV afterload. Whereas in most cases, the higher SVR that your body does in shock states to try to compensate is a good thing. It's helpful. In cardiogenic shock, it often can be hurtful. So the end result here is low forward flow, low cardiac output that leads to tissue hypoperfusion. You'd have elevated pressures in your heart because you can't pump all that blood out as efficiently. That'll lead to pulmonary congestion, pulmonary edema, peripheral edema, and you can't get enough oxygen delivery to all your tissues or your heart, and it starts that spiral, right? The heart is a big muscle too, so if you can't pump enough blood to your heart through those coronaries, the heart muscle is already struggling, and it'll start to struggle more because you'll get myocardial hypoxia, just like you get tissue hypoxia throughout your body. All right, hemodynamics and oxygen consumption. So this here is kind of generic, right? Every subtype of cardiogenic shock behaves a little different, but this is more kind of test question generic. So we'll talk about a parameter and we'll talk about whether it's higher, lower, or the same in cardiogenic shock. The mean arterial pressure. Sometimes it can be normal and you could still be in shock, but most times for the test questions, it's low. You're hypotensive. You have a low MAP. Your cardiac output in cardiogenic shock is obviously going to be very low. That's one of the hallmarks of cardiogenic shock is low cardiac output. Your systemic vascular resistance, your SVR, we just talked about it's going to be high because your body's going to be vasoconstricting the blood vessels to try to maintain that MAP. And we also talked about how this sometimes can actually be bad for the heart when you get this high SVR state when you vasoconstrict because you stress the heart out more. Your central venous pressure is going to be high because all that venous blood trying to flow into the heart can't pump it all out. So you get kind of backflow, you get venous congestion, you get high CVPs. And then oxygen consumption is somewhat of a more advanced topic. We might do a separate episode on that. But in cardiogenic shock, you kind of have impaired delivery of oxygen, even though you're still extracting just as much. So that's going to lead to a low SVO2. But again, it's a little more complex. All right, what about the subtypes of cardiogenic shock? I mentioned, there's these subtypes and they behave slightly differently. So let's talk about the subtypes. So we said the most common is acute myocardial infarction related, AMI related. And within each subtype, we're going to talk about the pathophysiology, the classic findings, and the initial treatment. So the pathophysiology of acute myocardial infarction related cardiogenic shock is your left ventricle fails. You have LV pump failure because your coronary got obstructed and that left ventricular myocardial muscle got ischemic and started to die. So you have LV pump failure. So the classic findings are these patients often, have STEMIs or NSTEMIs, ST elevation myocardial infarctions or non-ST elevation myocardial infarctions. If they're infarcting their myocardium, they're probably going to have chest pain. If it's gotten so bad that their heart is failing, they might have signs of fluid overload like pulmonary edema. And the initial treatment, you could use inotropes to try to bridge these patients, but they really need revascularization, right? They need a stent or they need a CABG, coronary artery bypass graft. And sometimes they need MCS, mechanical circulatory support, to support that sick heart while they're trying to revascularize it. All right. What about arrhythmic related cardiogenic shock? Cardiogenic shock that resulted from an arrhythmia. Pathophysiology here, it could be tachyarrhythmias, it could be bradyarrhythmias. All these things can cause shock. They can impair filling, they can impair contractility. All right, the classic findings are going to be palpitations. You might feel the arrhythmia. You might syncopize. You certainly will have unstable rhythms on your EKG. So these are some of the classic findings. A patient comes in with palpitations and syncope and they're cool to the touch, they're confused, they have renal failure, a high lactate, they look fluid overloaded. That might be a patient who's got a arrhythmia-induced cardiogenic shock. And really the initial treatment is to try to get them out of that malignant rhythm, right? Shock them back into sinus, or if they're bradycardic, pace them back to a normal rate. Give them antiarrhythmics to address that underlying cause. Or what about valvular causes of cardiogenic shock? This is usually acute in origin, although it can be chronic. Severe aortic stenosis and all those things can build up to the point where it can cause shock. But you also can get things like papillary muscle ruptures leading to acute MR, or your prosthetic valve might fail. So there's multiple different valves that can lead to cardiogenic shock. The classic findings, though, if it's acute, is going to be sudden onset pulmonary edema. If it's a papillary muscle or chordae rupture, sometimes that pulmonary edema will be unilateral because that jet might just be pointing to a certain pulmonary vein, leading to pulmonary edema just in the territory of that pulmonary vein, right? You might hear a murmur from the valvulopathy. And these patients might need mechanical circulatory support. Most of them will need surgery to fix that valve, whether it's invasive or, minimally invasive. And then another cause of cardiogenic shock is myocarditis, right? This is usually global myocardial dysfunction. That whole myocardium is inflamed and not working. Often it's viral in origin, although there's multiple different causes of myocarditis. And then these patients, again, might need MCS, mechanical circulatory support, to bridge them. If it's refractory, they might need a transplant. And in the interim, they might need inotropes to help that heart squeeze. Again, we've done lots of episodes on inotropes, so check those out if you're interested. So those are the main causes of cardiogenic shock and the management principles. Again, heart failure progression is somewhat of a unique beast, so we didn't include it here, but we plan to cover it on a future episode. So management principles here we've already talked about, but we wanted to dive into them a little bit more. From a pharmacotherapy standpoint, we said inotropes a lot. And we've covered inotropes in detail in multiple episodes, so just search Whiteboard Medicine inotropes, it'll pop up. But the two main ones are dobutamine and milrinone, and inotropes increase the contractility of the heart. They make the heart squeeze harder. And we said that pump function is one of the big problems of cardiogenic shock. So if we make it squeeze more, it will pump more blood out. One of the issues, though, is when you're forcing the myocardial muscle to squeeze more, you're forcing it to use more oxygen. And if you already can't deliver enough oxygen, that sometimes worsens myocardial function in the long run. But if the patient's going to die without it, you got to do what you have to do in the acute phase. These inotropes also increase the risk of things like arrhythmias, and they usually cause some vasodilation, which can lead to hypotension. Okay, vasopressors. Norepinephrine is usually the preferred vasopressor if there is some hypotension related to cardiogenic shock. So it's not uncommon for patients to be on both inotropes and vasopressors when you're doing pharmacologic management of these patients. Definitive treatment, as we talked about, is going to be etiology specific. So for acute myocardial infarction, immediate PCI or CABG. This is critical. These patients need to get revascularized. They need to have return of flow to that myocardium. Valvular failure, right? They need to fix the valve. Arrhythmias, you need to fix the arrhythmia. So all this is, somewhat straightforward in terms of addressing the underlying lesion or nidus or illness. And then mechanical circulatory support, we have multiple episodes on mechanical circulatory support. Again, just search whiteboard medicine, MCS, and it'll pop up. But just briefly, intra-aortic balloon pumps, Impellas, tandem hearts, and ECMO are some of the MCS devices we will use. The evidence for balloon pumps is not robust, although there still are sometimes used. They reduce afterload and augment coronary perfusion. We have an episode specifically on balloon pump. Again, just search it and you'll find it. Impellas are left ventricular assist devices, right? They can offload the left ventricle and increase perfusion. And then VA ECMO, again, we have episodes on VA ECMO as well. Just search whiteboard medicine ECMO. But this is kind of the highest level of, organ support available. Where you put cannulas into a vein and artery and you suck blood out of the body, oxygenate it, and pump it back into the body to kind of bypass the heart and lungs. Adjuncts, diuretics, and nitroglycerin. This is somewhat blood pressure specific, but if you have someone with worsening heart failure who looks congested, diuresing them and giving them some nitro to vasodilate them can be helpful. Really avoid excessive fluids. Hypotension in these patients does not mean they need fluids. They do not need fluids. Fluids can be detrimental. So don't reflexively give hypotensive patients fluids unless you know that they are volume down. Okay. Landmark trials, just briefly. We're not going to dive into all these, but we always like to leave some trials on here for those people who are nerdy like us and like to know trials. There's been a couple big trials. There's been actually a couple more since we have put this together. But the shock trial, IABP, shock 2, culprit shock, and some MCS studies are just looking at different mechanical circulatory support devices, mortality, all that good stuff. So these are just a couple of the trials to wet your whistle, but certainly dive into the larger literature. There's a lot out there and a lot evolving on this, particularly related to different mechanical circulatory support devices. All right, let's get into some practice questions. For those of you who have not done practice questions with us, we'll have a beginner, an intermediate, and an advanced practice question. We'll read the question and the answer options, and then we'll dive right into the answer. So if you need more time to think about it, just make sure to pause the episode because we'll go right into the answer. So question 1, the beginning level. A patient with anterior STEMI develops hypotension, pulmonary edema, and cool extremities. Which type of shock is most likely? A, distributive shock, B, hypovolemic shock, C, cardiogenic shock, or D, obstructive shock. Hopefully all you got this, even if you didn't read the question, just by context clues with this being an episode on cardiogenic shock, the correct answer is C, cardiogenic shock. This patient had a STEMI. Okay, so an ST elevation myocardial infarction. Now they're hypotensive. They have signs of venous congestion, aka pulmonary edema, and they have cool extremities, which tells you they have a high SVR, aka vasoconstriction. Okay, so that all adds up to cardiogenic shock. Distributive shock usually has warm extremities because they have vasodilation from all the inflammatory mediators. Now, hypovolemic, cardiogenic, and obstructive all have cool extremities. Okay, hypovolemic shock would not have signs of venous congestion. They would not have pulmonary edema. So that's how you know it's not hypovolemic shock. And then you're between cardiogenic and obstructive shock. In this question stem, it says the patient has a STEMI, and that is why it's not obstructive shock because they don't have a cause of obstructive shock. They have a cause of cardiogenic shock. Now, one could argue maybe they have a ventricular free wall rupture and they have a huge effusion, which fine. But common things being common, cardiogenic shock. Question 2, intermediate. Which of the following interventions has been shown to improve long-term survival in patients with AMI-related cardiogenic shock? A, high-dose inotropes, B, routine intra-aortic balloon pump placement, C, early revascularization, or D, aggressive fluid resuscitation. We did not dive into some of the balloon pump literature. Our hope is that based on what we talked about, you can get to the bottom of this question, but it's a tougher one for sure. All right, answer is C, early revascularization. So what we talked about is AMI, acute myocardial infarction-related cardiogenic shock, you have to revascularize. That is what helps patients. So giving them high-dose inotropes, making that heart work in overtime, is just going to cause more myocardial muscle injury. Routine intra-aortic balloon pump use, we did mention, although didn't dive into it, that it does not typically improve outcomes. And then you do not want to aggressively fluid resuscitate these patients because they have venous congestion. So you have to fix the underlying lesion, which in this case is early revascularization. All right, advanced question, last one. Which of the following hemodynamic profiles is most consistent with cardiogenic shock? A, decreased cardiac output, high SVR, high CVP. B, decreased cardiac output, low SVR, low CVP. C, increased cardiac output, decreased SVR, normal CVP. Or D, normal cardiac output, normal SVR, high CVP. Pause if you need to. The correct answer is A, low cardiac output, high SVR, high CVP. So let's break that down. We said cardiogenic shock. Cardiogenic shock is a pump problem, so you're going to have low cardiac output. So right then and there, you know that the answer has to have low cardiac output. We also said we know that you get venous congestion because the heart can't squeeze all the normal blood out. That venous congestion leads to a high CVP, a high central venous pressure. So you know the answer has to have a high central venous pressure. That alone gives you the answer. But as a little bonus, what does the body do to try to compensate? It vasoconstricts. It has a high SVR. That's how you know the answer is A. Low cardiac output, high SVR, high CVP. All right, that is all we have for you today. Hopefully that was interesting, helpful. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.